Today on Surfing the NASH Tsunami.
And my last point, which is probably the most controversial, which is why I left it to the last part, is we have to be a bit introspective and say, is it the NITs that aren't good, or is it the drugs that are not good? If you want 100% sensitivity and specificity, you will not get it.
If we have an indeterminate zone of 30%, and then we've only got 0.8s on both sides of it, that doesn't feel terribly efficient. It's better than nothing, don't get me wrong, but it feels like that's a zone that needs improvement.
Join hepatology researcher and key opinion leader Dr. Stephen Harrison, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, hepatology researcher and clinician Ian Rowe, as they preview next month's NASH 2021 meeting from their own unique perspectives on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH or, more broadly, fatty liver disease, Surf's Up. Season 2, Episode 21 of Surfing the NASH Tsunami. First day of the 4th Global NASH Congress starts now. So, day one wrapped up with a talk from Suneil Hosmane, who, as luck would have it, got off that talk and immediately joined us in the recording session, along with Louise Campbell, Jörn Schattenberg, and Manal Abdelmalek, who I believe will be here shortly. It's a special day for us, mostly because it's Jörn's birthday, and he was good enough to take an hour out of his birthday to join us before heading off to his birthday dinner. Jörn, as I think I said in a note to you earlier, I now owe you a piece of cake as well as a drink when I finally get to meet you in person at the end of all this. And now let's dive right into this episode so we can get Jörn off to his celebratory dinner as quickly as possible. Special icebreaker. One thing you heard in this morning's conference that got your attention and why? Bonus points if it's not on a presentation you're already discussing. Brave one, go first.
Oh, I'll be brave and I'll jump in. The most interesting thing I heard today was, or the most entertaining thing I heard today was this question by Michael Fuchs to Lauren Castera in regard to more access to primary care physicians for elastography and things like that, where Lauren said, that's the future. Love both of them. It is the future and it's desperately what we're trying to make available. So the future is here. Mm-hmm. So I love that comment and I'm in love with both of them for that.
I in fact, told Louise as she was in swoon over that comment that I would have to introduce her to Michael so that he could feel the energy. Suneil, Jörn, somebody go ahead.
I can give it a stab. It wasn't so much as what was said, but what wasn't said, but what could be inferred. And so I was listening to the SomaLogic talk this morning, and elegant system, multiple biomarkers, 30-something to kind of identify NASH and various features. And the Orock of that whole thing was like 85, and that kind of tells you, in NASH, we talk about the biopsy and what it could potentially mean. It seems like there may be an asymptote in that high 80s. That is the pinnacle of what you can achieve. And so we really shouldn't be setting ourselves up for like an abnormal, astronomical, you got to be 100%. I think mid to upper 80s, I think that's great. And that should be the bar.
I actually had a similar reaction. I think there are two possibilities. One is it's flat out asymptotic, and the other is where one level of knowledge, there's one key that nobody's unlocked yet that's got 7 or 8 of those final 15 points or 12 points in it, and we just don't even know where to look for it yet because people are looking everywhere they know to look, right? So someone will stumble on it.
Yeah, and the next thing is there's always the noise of the reference standard in there too, so I think probably beyond 90, we're not going to see many biomarkers outperform here.
So in that case, there are no more keys. Then if we're in the high 80s, then we're probably just about done, as Suneil suggests. So, Jörn, what's yours?
So I was remembered of my biochemistry classes again in med school because I took a deep dive into the abstracts that dealt with fructose, and I was reminded that the way fructose metabolism runs is through a hexokinase. And interestingly enough, the hexokinase converts fructose, but it's not slowed down by its product. So this is in contrast to the glucose metabolism, where you have a break on there, a physiological break, if you like. But if you feed yourself with fructose, that machinery just keeps on running and leads right into your lipid deposition in the liver. I knew that, but I felt it was interesting to see that molecular switch again, that's actually not stopped by its product and keeps on pouring out substrates to be converted into hepatic triglycerides.
Now, I'm going to run all the way to the other end of the spectrum on this. We go to these meetings and we go to events, and what we see is breakthroughs in science, innovations in science, large, small, etc., but they all tend to be about science. I thought the presentations Manal is going to be talking about when she gets here, from Glimpse Bio and Owlstone Medical, took a very different view toward towards what innovation is, which is fundamentally, we talk about non-invasive testing. Well, they've gotten to a different level, which I'm going to call non-intrusive testing, a breath biopsy and a urine test. So now you've got no machines, you've got no needles, you've got no blood work. Occasionally you find somebody who has concerns about urinating in a cup, I guess. But short of that, this is about as unintrusive a set of technologies as you could get to. And it's one of the few times I've seen people actually focus on doing consumer-friendly medicine at that level for a disease that isn't already worked through on all the science. So I thought that was spectacularly interesting. In fact, at NASH 2020, my comment was that I think the winners will be the diagnostic models with little or no capital expense involved. We've now gone past no capex. We've gone towards little or no intrusion or grief on patients. So I think that'll be really interesting to see as it develops. All right. With that said, let's go on to our episode. This is going to be really straightforward. Each of the five of us has signed on to talk about 2 or 3 different presentations with a common theme. So take about 8 minutes, talk about the presentations that you're covering and the common theme, and then the rest will also comment and ask questions. Then we'll go on to the next one. We will start with Jörn, because that way we'll be certain to get you out on schedule.
Thank you, Roger. Yes, and by now I'm unmuted. As I mentioned, I looked at 2 presentations that claim to be related to fructose metabolism. And the first one is given by Kendra Benz from Pfizer. And I'm going to detail that in a little bit more length. The second one is the 89 bio compound that was given by Hank Mansbach, that long-acting FGF21 analog. They focus on patient population that has severe hypertriglyceridemia. And I think we've seen some of that data before, but I found it was interesting to assess the degree of response they're seeing. So let me start out by the Pfizer compound, and Kendra actually goes back, and as I mentioned in my intro, details a little bit on fructose metabolism, which I found particularly interesting because I didn't remember all of that. And actually, fructose is metabolized in the intestine to a good extent, and there's a certain metabolic feed-forward loop that affects a type of nutrition, and she called it a vicious cycle. I couldn't remember that. And of course, then if you have an overfeeding with fructose, a lot of it goes to the liver, and then it's metabolized to the liver. And the way it's done, it's a ketohexokinase or fructose kinase that converts fructose into fructose 1-phosphate. And the key thing here is that machinery just keeps on pouring out fructose 1-phosphate, which fuels hepatic de novo lipogenesis. And in contrast, for example, to glucose, where glucose 1-phosphate stops the hexokinase that converts it, this one is not stopped. And I think that's a major factor if you're looking at fructose-rich diets. And she detailed some preclinical data. So I thought it was an interesting talk because it gave us both impressions from the preclinical developmental side and also the clinical phase 2A study that I'm going to come to later. So the preclinical data she showed first, it inhibits the ketohexokinase well. The ketohexokinase inhibitor is called PF06835919, and they used it in rats, and they were actually able to show that it decreases hepatic triglyceride content in those rats, and it seems that the fructose is actually excreted into the urine in those rats that do receive the inhibitor, and they saw a dose-dependent effect. So that worked out pretty well in the preclinical models. And they did a second model, overfeeding, which they called an American type diet, 14% of energy coming from sucrose and 31% fat. The animals in that time frame developed hepatic steatosis and insulin resistance, and that was prevented in a dose-dependent manner, different doses of the 5919 ketohexokinase inhibitor. So it worked out well in the animal models. Now, I didn't see a single data set on, let's say, transaminases or histology wasn't shown. I guess this is something I would have liked to see. And she mentioned that the paper is going to come out soon. So I guess it might be in there. I haven't gone back to visit that. But looking at that model, again, it's a metabolic model. It's not a NASH model. It's not a fibrotic animal model. So you're going to see metabolic derangements with hepatic steatosis and insulin resistance, but probably not a lot of inflammatory NASH. And I guess that's the preclinical part that she addressed. And then she went on and detailed a phase 2A study that was performed over 6 weeks with the same compound. 53 patients were enrolled. She detailed baseline characteristics and highlighted that only a third of them were type 2 diabetes patients, all of them obese, BMI above 30. And I think it was an even split between the 3 groups. They had placebo versus 75 versus 300 milligrams of PF06835919 per day, and that was given for 6 weeks. So the primary endpoint in that analysis was the change in MRI-PDFF measured, as I said before, at 6 weeks, and they had a number of secondary endpoints, including adverse events, safety, and clinical labs. And the primary endpoint was changed in that extent that the kinase inhibition in the high dose resulted in a decrease of the MRI-PDFF by 23%, I believe it was. So it didn't quite make that 30% we've been discussing previously at that in the podcast to be predictive of histological improvement, but then be reminded that it was really short. This was 6 weeks only. And I think she also tried to highlight that this is only 1/3 of patients that had diabetes. So I think it felt to her that this might be something where you then do not see as extensive movements in the hepatic triglyceride content. And that's the strongest data point in my view. The talk went on and they highlighted that there are some changes in the levels of CRP, adiponectin, and IL-6. So CRP decreases at the high dose, adiponectin increases at the high dose, and IL-6 decreases at the high dose. But that data is not very robust, and I think the CRP is not it's not a great marker, and if anything, it correlates with steatohepatitis. We don't know how much steatohepatitis there is. The adiponectin going up is nice, and it shows that the adipose tissue here is participating in these changes once you inhibit that hepatic de novo lipogenesis, and IL-6 going down, that wasn't a major effect, and it wasn't statistically significant. So overall, I thought it was a very complete talk detailing preclinical data, providing evidence that it works as a metabolic drug and improves hepatic MRI-PDFF, hepatic triglyceride content over 6 weeks. And she also mentioned that they just completed a 16 weeks study, but those results aren't out yet. So I'll be looking forward to that. To me, a mostly metabolic mechanism of action, and will be interesting to see how that fits into that treatment landscape we're seeing. So the 89bio data was presented earlier at AASLD, and you can actually go to the website and look at the posters that detail those studies. 89bio introduces an FGF21 analog, glycopegylated FGF21, and it's given Q weekly, I believe. The data they presented was in a group of patients in a phase 1b/2a trial design, increasing doses in patients with increased hepatic fat content determined by MRI-PDFF. They had a 12-week treatment duration and a 4-week safety follow-up, and it included a placebo. So the most dominant finding was that MRI-PDFF reduction seen at week 13, and when you adjusted that to placebo, they saw a 70% decrease at the highest dose. Now, the Q weekly was explored in 4 doses, 3, 9, 18, and 27 milligrams. It wasn't a clear dose response on the MRI-PDFF, but again, at the highest Q weekly dose, 27 milligrams, the liver fat went down by 70%. And they also had a 2-weekly dosage, and here at the 36 milligrams, they used a comparable level of fat reduction was seen. So overall, robust reductions in liver fat and a decrease in ALTs were seen. And something that they highlight in their study is that the normalization of triglycerides occurs in a fair number of patients with elevated triglyceride levels at baseline. So half of the patients with triglyceride above 200 actually do normalize their triglycerides. So here the mechanism of action really impacts on hepatic de novo lipogenesis and also decreases hepatic triglyceride content. All in all, I think it was interesting to see the robust effect on hepatic fat content, in particular in the high dose group Q weekly. And I think, again, this is something, in particular, if you look at the triglycerides improvement, that could also be used in combinations, for example, with drugs that do lead to lipid abnormalities at the same time.
Thanks, Jörn. That's great. And really fantastic summary. Suneil, Louise, questions?
I suppose I had one question on the fructose, on the practical side from a person perspective, because obviously if the majority of fructose was metabolized in the gut, it leads to the high fructose, high sucrose drinks. Is it the actual speed that we consume that high fructose that causes the deposit of liver fat? And just for when we're talking to children, or we do in school education, about how they consume, is there a way that people can still consume those high drinks, but in a better way? Does this sort of information help us with that?
That is a very good question. I don't have all the answers. So to me, when I listened to the talk, it reminded me of a situation where in the development and in previous times, the exposition to sucrose and fructose just wasn't as high. And that's when fructose was primarily metabolized in the intestine, and our current environment, we're seeing a fructose overload, and it kind of spills over into the liver. Now, I'm not the right person to detail all that and saying that this should only be intestinally metabolized, but it sounded to me like this is an adaptation that occurred related to our overnutrition, and our organism just hasn't adapted dynamically enough to get rid of the fructose in the intestine. And that fructose that actually reaches the liver is really that fructose portion that fuels the hepatic liponeogenesis and adds to the NAFLD disease burden. And I guess the counseling with the kids should be really to reduce the uptake. And I don't think it's about the speed. It's about the overall exposure is what my take home was here.
Thanks. That's helpful, and I think would have been the operant hypothesis. I don't recall any other papers that talk about 6-week PDFF, but you're far more learned and remember far more stuff than I do. Is there anything that has a 6-week PDFF number in it besides this?
That is a good question, Roger, and I think most look at 12 weeks. We've seen some 8 weeks, and I think I saw 4 weeks once, but I can't remember which compound this could have been. It tells us that the effects we're seeing from the ketohexokinase inhibition are fast. The fructose is pouring into the liver, and by blocking the ketohexokinase, you excrete fructose to a higher degree in the urine. That kind of reminded me of the SGLT2s and then I was thinking, maybe they have more urinary tract infections, but that didn't come up. At least I couldn't find it. That'll be interesting to follow. Maybe, I have to do some additional reading and look at the intestinal and the fructose renal secretion here. But again, the changes, the degree of change is almost being close to that 30% of MRI PDFF reduction in 6 weeks. I thought that was impressive.
I agree. It's a striking number. I was just wondering if there was any way that we could even conceptualize what a curve might look like on that. The answer, I guess, is not that you or I are comfortable doing on this session this evening.
Yeah, I think it's difficult to pair it up with previous studies. Again, remember, this is a purely metabolic patient population, obese patients, 1/3 diabetic. It's a metabolic study population, difficult to compare with others. I think females were kind of low in that group too.
So Suneil had a question. He's left us for a second because we're going to try to see if we can get his audio back. But the question was, given that Pfizer, he believes, recently halted their program in NASH, are these types of presentations, in your opinion, I think, Jörn, it's to you, an indication that they're still pioneering new science in NASH? Are you aware of anything on that subject?
Interesting question. And I can only say, obviously, what's in the open domain too. To my understanding, they've also looked at partners and are thinking about, combining with other partners. And I can't speak on Pfizer's behalf, obviously, cannot tell you where they're going or what's happening. I thought it's an interesting compound. It does give you obvious changes, and we'll see where they take it.
Thanks, Jörn. So first of all, let me let everybody know that Manal has heroically arrived. I now have two heroes today. Jörn, because it's his birthday, and Manal, because her endoscopy schedule ran late, and she scrambled to get here as quickly as she possibly could. Hi, Manal. How are you today?
Hi, everyone. How are you?
We're fine. You have to wish Jörn a happy birthday.
Oh, happy birthday, Jörn.
Thanks, Manal.
And Suneil will be back on in a second. He was rebooting because he was having some problem with his audio, but he asked a question that you might actually have a better answer to than any of us, which is, Jörn talked about the Pfizer KetoHex presentation today in fructose metabolism. And Suneil's question was, given that Pfizer recently halted or cut back on their NASH program, or so I recall, is his quote, are these types of presentations, in your opinion, an indication they're still pioneering new science in NASH?
Yeah, I do. I think they're very important in not only pioneering new science, but also validating prior understanding of the pathobiology of this disease. I mean, we've always known that fructose, for example, is a very potent inducer of de novo lipogenesis, liver injury, and fibrosis. And to see the mechanistic proof of concept in blocking fructose metabolism with hexokinase inhibitor is validating. It's a pivotal proof of concept for a major modifiable risk factor for NAFLD NAFLD and NASH. And really, ideally, one could argue whether all patients should stop drinking sodas and eating high fructose containing foods. But the reality is it is so endemic in our food industry that an abrupt discontinuation of fructose in the diet may not be completely feasible or achievable for that matter. I think what Jörn presented is important. I think what Pfizer has done is also important. But practically speaking, we can get the same effect if we could really just get patients to comply with very low fructose diets.
Welcome back, Suneil.
Sorry about that.
No, now you sound like Suneil again. We're all happy. And Manal has made it back in the meantime. So, Manal, I'm going to ask you the question I asked everybody at the opening, and then I'm going to ask you to, because in respect to your schedule, dive in and discuss the papers that you were planning, the presentations you're planning to discuss this morning. One thing that arose this morning in this conference that you found striking?
I think what's striking is the robustness and the innovation by which the biomarker development field is moving forward. That is incredibly striking to me. We've been hinged on imaging biomarkers. We've been hinged on blood-based biomarkers. We've really evaluated the strength of even bedside risk assessments such as FIB4 and NAFLD fibrosis score or APRI. And what we're starting to see is a transition to the assessment of point-of-care potentially biomarkers, whether that be urine assessment, proteases, or even breath tests for volatile organic compounds. And the one promise is if we are able to achieve really sensitive and specific point-of-care biomarkers as simple as a urine test or a breath test for this disease, that would be key, not only with regards to potentially lowering cost of biomarkers where you're not performing very elaborate, high-cost, throughput omics, metabolomics, lipidomic, proteomic type platforms. And I do anticipate those costs will come down with time, certainly, but really empower the primary care physician to do an office-based test. And I think what we're seeing is we're getting closer to that. The challenges, of course, that exist, fascinating presentation that I thought that was presented by Gillespie Fernandino, evaluated the AL biomarker, which was a breath test that assessed literally over 1,000 volatile organic compounds in the breath. And they evaluated patients who had cirrhosis and cirrhosis with liver cancer, and even patients who had healthy controls. And granted, it was a very small pilot project, but they were able to discern is there was one volatile organic compound, limonene, that was detectable in the breath of patients with cirrhosis and patients with cirrhosis and liver cancer, although there wasn't much difference between cirrhosis and cirrhosis with liver cancer compared to the controls. And as they drilled down and presented their data, what they ultimately noted is that there's correlation between this limonene and other markers that are known to be predictive of liver function, such as bilirubin or prothrombin time or even albumin, suggesting that not only do we have a point of care, but one that could predict synthetic function in reserve. As I was listening to the presentation, my thought is, wow, this is very exciting, but really how much such markers could be confounded by other disease conditions, whether it be bacterial overgrowth of the gut or whether they could be even heart failure or dietary composition, high fat, high sugar diets. We know that these volatile organic compounds can change, and they could potentially change over time and not completely be reflective of underlying liver disease. What would happen if somebody took recent antibiotics, for example? So a lot of unanswered questions. I think they're just starting to scratch the surface of the potential for volatile organic compound breath testing, but I think it opens up a Pandora's box also about really assessing how real world these type of assessments can be when you weigh into it dietary changes, medications, exposure to antibiotics. Would they really be reflective of underlying liver disease or other metabolic milieu in general for patients? But I thought it was still very innovative that a breath test could stratify health from cirrhosis, irrespective of the presence or absence of liver cancer, and really correlate more so with a marker of function. But I think there's a lot in store for these type of technologies, and time will tell what we see.
Yeah, so both Suneil and Manal highlighted the biomarkers, and I totally agree. I think it's this part of science that's rocketing here and really moves forward. So I'm very convinced this is going to be one of the major breakthroughs in the near future. And Manal, the story you've been telling, I'm thinking back to a paper I saw at AASLD once where the dogs were actually able to smell. I don't remember, either it was cirrhosis or cancer. And it's so obvious that you're able to quantify those changes now using those technologies. So I strongly agree. And while you're saying there's variability, it can also speak to personalization. So maybe when we understand better what drives which compound, we could then use this to personalize the whole approach and treat persons based on that. So I agree with both of you. It's a fascinating area.
And then the other thought I had was really just a kind of a simple, silly one, right? But we asked people to do fasting glucose. We asked people to do fasting lipids. I could envision a point at the future if it turned out that you could control the variability where we asked people to do fasting breath. It's a funny thought when you think about it, but it's not completely out of the question if that's what you needed to do to control better. Now, Manal, I take your point. Breath is so much more environmental than anything else is. And what they're talking about is so specific. But, all this is possible. I guess we have to see where it goes.
It was, if I misspoke, it was from Alstone Medical. So I think it scratches the surface for the potential of point-of-care biomarkers and really just opens up a wealth of opportunity by which to look at the robustness of these volatile compounds as they would otherwise perform in the real world, with various confounders introduced. Because certainly the last thing we need in a very highly prevalent disease is a point-of-care test that lacks any sensitivity and specificity based on environmental dietary exposures. However, they are able to detect differences between endogenous and exogenous volatile compounds. So maybe with time and additional modeling, we can tease out a more optimal sensitivities and specificities for what really matters, and what a doctor needs to be able to ascertain is beyond just the presence of cirrhosis alone. So a lot of work to be done, but very exciting work.
That was the Owlstone. Did you have any reactions to the Glimpse Bio, to the urine-based?
I think the Glimpse Bio is looking at urine proteases, and really I think the same concepts and principles apply with these new technologies. While the platforms are different, the innovation is high, the risk to reward ratio is also very high. And at the same time, I think we need to define with more granularity how these biomarkers perform across the spectrum of disease, whether they in fact can serve as predictive risk stratifiers for outcomes, which is ultimately what we care about. But both, interestingly, are teasing out unique markers that are altered in the context of metabolic disease and metabolic risk.
Yeah, and NASH 2020, where we met, one of the comments I made there that you actually and I talked about later privately is the idea that the winner in diagnostics is going to be low capex or no capex. The capital expense ultimately is going to be the enemy of primary care treatment. But if these things work out, then you actually not only have no capital expense, but you have low intrusion, right? People aren't going to have a problem breathing, and only relatively few will have a problem with urine. So you've now got the ultimately patient-friendly delivery of test materials, assuming, as you point out correctly, that they can then be interpreted relatively free of environmental factors. Suneil, let's let Louise go next. It's later in the day in the UK than it is here. So, Louise, what would you like to cover off on today?
I did 2 sessions. One was Lauren Castera, who was the lead session for the day, who's Professor of Hepatology in the University of Paris. And the second one was Andreas Gier. And I apologise now to any Germans, Jörn, who's the Professor of Internal Medicine and Hepatology at Würzburg University in Germany. Now, both of their conversations looked at non-invasive technologies and the state of the art now, and basically into screening in primary care and who to screen. So I'll start first with Lauren's session this morning. So he basically did a very nice summary of the current position of non-invasive technologies, concentrating on a number of points. Can they diagnose NAFLD and NASH? Can they replace biopsy? Can they be used in the real world? And can we enrich for that? So when he was looking at diagnosing NAFLD, he focused on CAP, which is obviously a component of FibroScan, and MRI PDFF. So ultimately, the advantages for CAP, it's point of care, it's widely available, but it's not as widely available looking at most of the sessions today as people tend to think. Looking at Andreas Gier's presentation, only about 24% of people access FibroScan, and it's primarily where it's located. But it does concomitant liver stiffness, but its disadvantages, obviously the quantifications are suboptimal for the CAP. There's a lot of discussion of where 5%, 33%, 66% steatosis markers are, and they're all quite high. They're all in the 300 range realistically in a US multi-center XL probe study and also in the UK multi-center XL probe study. So they put that against MRI-PDFF, which obviously has great advantages. It's highly sensitive, it's precise on steatosis, and it is the gold standard of non-invasive technologies. Its disadvantage is the time consuming, it's very limited in availability, and it's a high cost, and obviously not a lot of people can get through it. But head-to-head, CAP is well outperformed by MRI-PDFF, and I don't think there's certainly any argument from me on that. But CAP was promising in that it was rapid and standardized steatosis point of care, despite its suboptimal. But there was no consensus on the cutoffs, but above 275 decibels per meter, we get a 90% sensitivity. So that was really quite nice. When he then went on to looking at diagnosing NASH, he reviewed the obvious biomarkers and the scores, but made the conclusion that currently none of these are available, are sensitive or specific enough to really differentiate NASH from simple steatosis. Transient elastography and MRE neither can confidently discriminate NASH from steatosis either, so biopsy remains the reference for that. So we moved on to diagnosing advanced fibrosis. Obviously, we're all keen on the F3, F4, which is what we focus on in our clinical trials. So the serum markers had reasonable AROCs, and most of the validated serum markers for F3, F4 in NAFLD, FIB4, and NASH fibrosis score was simple, freely available, and widely available. Had AROCs greater than 0.8 and a high negative predictive value of 90%. ELF was patented. It was slightly higher performance, although there's less external validation and limited availability. So FIB4 non-fibrosis score versus ELF. The ELF was slightly better, but again, lack of widespread application, and it's limited by its cost and availability. They then went on to review elastography, and it's the technique of choice for point-of-care testing. It's available, it's less expensive. It's also one for me that, as I talk a lot, it's about interaction with patients and how they really interact with their condition and their own care. But the high negative predictive value, but suboptimal for F3, F4. But he then looked at redefining bovino with elastography, and the recent Papathilodoridi in Journal Hepatology paper this year did an optimal cutoff with dual cutoffs for chronic liver disease, and that was a liver stiffness of less than 8 and a liver stiffness above 12.5 kilopascals was actually a better way to use a dual cutoff to define serious disease. So when he summarised it, despite FIB4 non-fibrosis score and ELF, VCTE, so FibroScan and MRE were the most accurate to validate for assessing F3, F4. Use in clinical practice. Various different pathways were looked at into how we do first-line care in and around, but also using sequential non-invasive therapies for that. Can non-invasive technologies enrich trials? A very strong prediction for the FAST score, which we know is CAT plus liver stiffness plus AST, work done by Phil Newsome. So that came out higher than IS4 on that, but only marginally. Prognosis, ELF and VTCE were all able to predict prognosis of disease over time periods, and FibroScan was also able to pick up mortality. So in all of the areas that we want to be looking non-invasively, these technologies do work. So his take-home messages were ultrasound remains the first-line tool for detecting NAFLD. Liver biopsy will remain the first time for diagnosing NASH. All of the other are accurate and validated for diagnosing advanced fibrosis. And in clinical practice, the optimal strategy is sequential use of FIB4 NASH fibrosis score to rule out F3, F4, followed by FibroScan realistically. Now, a lot of that was covered again by Andres Greer, but his presentation was way more focused on how do we use this in primary care and what are the advantages to that and the obstructions. So he looked at NAFLD screening, which generally isn't done despite 20 to 30% of the population's affected. He identified some screening algorithms and the flow through primary care, also diagnostic algorithms and specialised secondary diagnostic platforms. But I think he summarised a lot of what Laurent Castera did. He he also focused on what we discuss regularly, that you cannot use abnormal liver function tests to identify patients predominantly at risk, so serum ALT elevated. But what he did go on to, which I thought was an excellent series, was he looked at NAFLD screening in the populations and used two studies, one in Italy, which was more of a diabetic population, so it wasn't general, and another one that was a UK population that was way more of a general population. And actually, it was significant for one reason, that he identified that 30 to 40% of patients is all we pick up through any of our normal techniques with liver disease, so that we are really, really missing a significant number of patients by not screening. He then went on to look at cost effectivity for screening with transient elastography and the number of needed to screen to make it cost effective. And it was as low as 7 in patients with diabetes. It was 12.5 in patients with alcohol. In NAFLD, it was 34.5 patients, and obesity, it was 8.5 patients. So the argument for not screening, I think he showed extremely well that we can do it. We don't need huge numbers to be able to screen. And I think if we look at some of the other areas of numbers needed to treat, it would come really highly. Again, he looked at through primary care and made the same conclusion that a lot of presentations I listened to today, that screening and availability to primary care physicians to transient elastography would be extremely helpful. He used the Camden and Islington pathway to go through some of that, but they've designed their own pathway whereby they used a questionnaire with primary care at the beginning. Then they would go to risk scores, FIB4s, and have a fast-track system for FibroScan. And what they said on one of the questions that he was answered, that actually significantly removed a number of referrals by doing it that way and then doing virtual appointments. So that, I thought that was a really good one. They didn't state, however, if they used the FAST score, and over 80% of patients were overestimated if they were bariatric, which I thought was quite interesting. But I think the other thing that did surprise me was the German model uses endocrinologists and nutritionists also look after NAFLD and NASH patients, but from their own experience in his centre, that only 11.7% of those patients from the endocrinology side get sent to hepatologists. So it was quite frightening. And I suppose going back to the question of what I heard today that I found really interesting, it was that 88.3% of patients sitting in their diabetes cohorts managed by endocrinologists are not sent to hepatologists, which he focused a little bit on screening pathways for EASL and ARSLD. And EASL do suggest that you have to screen in patients that are high risk with insulin resistance metabolic syndrome, but that would suggest by those figures that that's not happening. So I thought his was an interesting topic for many reasons, particularly the lack of endocrinology being referred through with the ones sitting through. So I think they both did good presentations on summing up what was available, but they did come to similar conclusions that ultimately transient elastography needs to be in a better location, primary care.
Any questions or comments for Louise?
I guess I'm not surprised by the low screening rates and referral rates from endocrinology at this point. Knowing the German system, I think it's also very dependent on the hepatologist that offers that type of service, because it's really about going and informing the colleagues and, picking them up, taking them by their hand and highlighting, there's compensated cirrhotics in your patient population and I can identify them with those tools you've highlighted. And I think that's where the absolute strength is. And I always remember patients with normal, thrombocytes, not abnormal, highly abnormal liver function tests, and they score 16 kilopascal on the first scan. And that's where the power of that technology kicks in and gives something back to the patient that we can then manage actively, even today in the absence of pharmacotherapy. And I think in the future, I would hope it will be easier because we then have hepato-directed therapies to offer starting at lower scales.
And I'm not convinced that because this wonderful abstract came out of Germany, that the rules don't apply everywhere else in the U.S. The same model exists, exactly as Jörn Jörn said, I think there's just a hub of patients sitting in endocrine clinics completely undiagnosed, probably with cirrhosis. And we have yet to really tap into finding these patients and really empowering non-hepatologists with the necessary tools by which to discover them earlier. I mean, just this week, I saw for the first time a decompensated cirrhotic from endocrinology whose message was, I never even knew I had liver disease and nobody ever looked.
Mm-hmm. Yeah. And I think I heard that repeated throughout some of the other sessions. One of the things that I didn't mention, which he picked up quite neatly, was that ARSLD they discourage screening in high-risk groups because of the current lack of treatment options. That's purely pharmacological treatment, which therefore leads to this suspicion that we're all interconnected with only promoting pharmacology. And there's a reason that people get suspicious. We have a lot of effective treatments, lifestyle, we have great dietitians, we have good exercise. The FDA is allowing 20 to 30% of people to go undiagnosed because of no pharmacological results. And he was very out there in that. And I thought that was Greer's talk, because he compared all the guidelines, and of course everybody else has at least something about assessing for liver disease in them, but ARSL still sits there and says no, despite what Manal's just said.
So let's say goodnight to Jörn and say happy birthday, enjoy your birthday dinner, and also I'll be speaking with you soon. Thank you very much.
Thank you for having me. Bye-bye.
Bye-bye. And Louise, so one of the points we've come upon recently is that, in fact, ARSL is now looking at redoing the guidelines, and it's fairly highly anticipated that type 2 diabetes screening is going to go into the next round. The point was it wasn't about not having drugs. It was about cost effectiveness, really. That if you couldn't do anything about it, then why were you going to screen for it? But Mazen's work on NITs has really, I think, shifted the landscape on that. And if you recall, when he was on talking about that, Stephen made the comment that was likely to happen on the next round, and this was why. So I think that'll help tremendously. Suneil, why don't you cover yours? I'll cover mine, and then we'll call it a day.
Sure. So I covered 3 talks. I think I'll go through them in pretty high level. And then I have kind of 2, I don't know why I feel controversial. I've kind of like 2 controversial sort of like summaries, I think, of them. In terms of the talks, first one was by Steve Williams at SomaLogic. I've met Steve years before, and it's really nice to see his platform evolving just at a super high level. They've found a way to do really high throughput proteomic analysis, not using standard proteomic equipment. Normally you have to do mass spec and kind of use expensive large equipment. He's able to kind of scale that down and use something called aptamers, which is, I'm oversimplifying, but it's a piece of DNA that's been kind of shaped in a particular way, and it binds things. It can bind proteins, and you can start to generate signal on various proteins. And that was sort of one of the big takeaways of the day is, with a very sophisticated system, looking at the whole universe of proteins, or a very large universe of proteins, finding a panel that's around 37 proteins to kind of really delineate steatosis from inflammation, ballooning, fibrosis, NASH, and the Orock, very good, but achieving that 0.8586 range. So from a blood-based biomarker standpoint, given the reference standard, it seems like that may be approaching a limit of possibility. So that's useful and helpful for the field in general when we're thinking about comparing and things like that. And it also tells you that there's a law of diminishing returns as you start to complexify the panel and you increase the cost. There's only so much you can eke out in terms of performance. So it's just an very interesting talk, great data. I'm looking forward to seeing more of that generated through trials. Second talk was on microRNA. So this is Rui Castro, but great talk on microRNA and kind of giving kind of a state of the art in terms of various microRNA biomarkers. And I think one thing that's just interesting is the liver is, as you know, a metabolic factory. It's a protein factory. And as a result of that, it's a biomarker wonderland, so to speak, and sorting through that is challenging. And from a blood-based standpoint, it seems like microRNAs have strong plausibility there, and there's been some great work. And I think he raised a great point at the end, which is we really need to think about how we standardize these analyses so we can really begin to compare and then move the field forward. And they're little nuanced points, but they're very important things, like how do you normalize a measurement? What's it in reference to? And those type of things, will begin to get ironed out out. So a great overarching talk. microRNA, the takeaway is microRNAs, particularly 122, 34A, and I think 19 or 21 had significant association with NASH and features of NASH and fibrosis. So more to come there, I believe. And the last talk was from Andrew Billen from Gilead. And I applaud Gilead for, in general, as a company, like no matter whether positive data, negative data, they're publishing it and they're getting it out there and they're moving the field forward. And I think we should all congratulate them for that kind of stewardship. And I think the most compelling thing that came to me from that data, I mean, there's many ways you could dissect all that data, but it was a very early slide and it was these Kaplan-Meier curves. And if you haven't seen those curves, you know, they're usually time is on the x-axis, y is like events or survival or something of that nature. And you see kind of the curves with differing levels or ranges. And what I thought was exceptionally interesting there was, you know, we already have data in the field for example, transient elastography, you know, like people with stiffnesses above 38.6 have the worst outcomes versus 12 to 38 versus 8. Well, I'm oversimplifying, or less than 8. And you have something similar with ELF, and you know, within our own program, we're trying to generate something similar as well. And you know, the blueprint for migrating clinical development from biopsy to NITs is right there. You know, that's the strategy. So, for example, if you enroll patients that are above 12, hypothetically, and you bring them below 8, that should be predictive of outcomes, and that's what these graphs show. And I think as we collect more data and we move that forward, we have that discussion with the FDA, I think, you know, them being fairly objective people would be at least conversational about that. So I think there are strategies to move forward. I don't know if the right conversations are being had with the people that have the data. So that's an interesting thing. But they went through all kinds of analyses in Stellar, and they were showing how from a lens of a biopsy, efficacy is X, but from the lens of an NIT, maybe efficacy is 2 times X, you know, and that's a provocative way of thinking because the NITs can kind of tease out more of the biology or different elements of the biology than the biopsy can, which leaves me to my controversial points. First one, I'm going to call it the 3 of 5 concept. And for anyone out there who went to the University of Illinois and studied engineering, you know exactly what I'm talking about when I say 3 of 5. When we're going through electrical engineering, surprise, I'm an electrical engineer. So that's when we're going through electrical engineering, the department wouldn't say you got to do, I mean, yes, there's some basic courses we take, but once we get to like the junior level, there are these 5 categories of classes and you have to pick amongst 3 of them. And they're all thematic. They may seem different, but they're all thematic in terms of the kind of core things you're learning. And I think when we think about an NIT strategy, we have to start thinking about a 3 of 5 list, meaning what do we consider to be first line diagnostics? Let's put stuff in that bucket and let's stop talking about it. Let's just, you know, do it. And what's second line diagnostics and what's third line diagnostics? So for example, and it all depends on availability and various factors, right? So we can put, you know, NFS and FIB4 as Cat 1. We can put VCTE, some of the serum tests like ELF, NIS4, you know, next generation FibroScan type technology, all these things in Cat 2, right? Pricing wise, availability wise. And then we put MRI technologies in Cat 3 and we say you have to do 2 of them, you know, or you have to do one of each, you know, one of all 3 categories. And I think by it removes it changes the way in which we're talking about it. It's not about me versus you. It's about, you know, getting the right level of criteria to get to your answer, because that's ultimately what matters. I don't know. I kind of like to see that. As I see all this stuff, I kind of think that way. And my last point, which is probably the most controversial, which is why I left it to the last part, is we have to be a bit introspective and say, is it the NITs that aren't good, or is it the drugs that are not good? Because if I put out an NIT strategy and a drug doesn't achieve it, does that mean my NIT sucks? Maybe. Maybe that your drug doesn't work, right? Or it didn't work the way that you thought, or you didn't dose it high enough, or you didn't dose it long enough. And I think, you know, if we just be philosophical for a second, let's say it takes hypothetically 7 years to go from stage to stage, yet you want to rapidly bring it back 1 stage in 6 months. What do you think your chances of success are? You know, I just put it out there to say maybe the NITs are not so bad, but maybe what we're asking of them is too much.
A couple thoughts. So first of all, it's a shame that Manal has left. Louise, I wonder if you know where I'm going, because Manal's been pretty consistent about this issue, that drugs should get approved simply because they stop decline. That, in fact, FDA has made clear that if you maintain and don't regress, stress, particularly in terms of steatosis, that's enough. So that would be in essence, that would align with what you're talking about. I think it's probably fair to say that the historic burden we've asked the drugs to carry is too high, which is why we don't have any drugs, by the way. So it may not be that either one is no good. They may both be good. We may just be asking too much of one or the other of them and maybe too much of the drugs.
100%.
I think I can speak reasonably confidently to say that if you ask Manal, that's likely where she'd go.
It sounds perfect to me, and I think I love controversy, and I particularly like the last one because I think it's what we see in the placebo if you look at it with the trials. It's not necessarily that the drug didn't achieve its goal, that the placebo overperformed, but they're all in a process, and you have to also judge the process. And if the process affects patients' health, then you look for a different marker within that, because that process improved those non-invasive technologies, it improved that placebo line, it showed an effect. It may not have hit the marker that they wanted because the placebo overperformed, but I can move somebody's liver fat with serial fibroscans every month for 4 months from 290 to 240. Now that is your placebo group way outperforming a medication, but it's the process, it's not. So I agree with Suneil here. I think we have to be, are we asking too much? Should we just be looking for that movement that several of the other presenters discussed in measurements? So I like your controversy.
Suneil, it's a shame you've been away for so long because it touches on several conversations that we've had that make this sound less controversial. One of them being the whole question around why is placebo so much higher in some trials than others, and the value of lifestyle and focused intervention and how much that can achieve over time. As I say, the second thing is Manal's question about why isn't it enough to maintain if in fact you've got people on a slope. The whole idea, which FDA and EMA both talked about today, that these are long-term progressive diseases, that the reason that we're willing to accept histologic endpoints is that for NASH patients, F2, F3, if you had to wait for clinical outcomes, you'd never approve anything. So, and in fact, it was notable that I was looking at the regulatory talks, and I'll come back to that in a second, but the most notable point to me is that in both those talks, they talked about the parallel strategy that if I recall correctly, I don't even think FDA brought this up concretely in the Jan 31 webcast. They might have, because Stephen was talking about it in our post, but I don't think they were explicit about this. The idea that you could do away with needing phase 4 if you ran an F2, F3, and an F4 trial in parallel.
I think they just suggested it as a strategy, not that it will be the thing.
Well, so I will tell you that they both suggested it as a strategy today, but Chappell went so far as to call it the American strategy because basically that's what they did. And I thought Makar was more bullish on it than the division had been at the end of January because we're coming to grips with the idea of what this disease is. Look, right now we think there won't be drugs until 23, right? Is the general assumption. But over the next 2 years, people are only going to get sicker and more people will come into the system. So I think improving the sensitivity of the tests will be of value and is of value precisely if it allows us to understand the value of smaller incremental changes, right? The test isn't failing if the patients don't get much better. Maybe what happens is if tests become more precise, we can lower expectations or we can accept less as a rationale for treatment, Louise, which goes back to, I think, where you were.
The one thing also is speaking like clinically, right? And you look at, you can take anything you like. You can take any biomarker that we routinely use, like HbA1c. HbA1c, if you look at kind of consensus guidelines across the globe, it's like 6.5, right? That you're now, at least that's a factor in whether you're a diabetic or not. But in reality, it's really not the case. I mean, if you look at if I plotted for you non-medicated diabetic patients across the spectrum, you would see people at 5, you'd see people, it's a wide spectrum, it's particularly around onset, affected by age, affected by gender, but we pick 6.5 to simplify the clinical algorithm, right? You can't have this super complex algorithm. You need to have something to rally behind. So when we think about it from a NASH perspective, as an example, we should just know that we're going to miss people. It's just the way it is, right? It doesn't really matter. It's biological variability. It's not, no one's trying to do ill will. It's just the way that it is. And we have to think of what's acceptable as a minimum. And then immediately, what's a risk mitigation strategy to capture those people that we didn't capture the first time around. And I'd love to see from the clinical community, particularly the guideline communities, like to put something out there to kind of put some sort of line in the sand so we can at least have a conversation about it. Because, once again, is it asking too much of the NITs? Like if you want 100% sensitivity and specificity, you will not get it.
Suneil, I think the thing that will be asked of the NITs is the indeterminate zone has to come down from 30%. So, one of the things about this being a more practical, less academic meeting was there was more focus on the idea that if you have a double marker, that's not practical. So if we have an indeterminate zone of 30% and then we've only got 0.8s on both sides of it, that doesn't feel terribly efficient. It's better than nothing, don't get me wrong, but it feels like that's a zone that needs improvement. And I know one of the things you and I have talked about offline without going into how or why is the work that you're doing right now and what can we do to slice the indeterminate zone? Because I think that's even a bigger question than are you going to get it all right on the sides? You know what I mean?
Yeah, and there's two ways to slice, and part of it's a mathematical abstraction. I don't want to get into like all the like philosophy or whatever, but I could either forget about any particular test. I can take a test and I can say, I'm going to optimize to rule in, I'm going to optimize to rule out. I want to bring those performance numbers as best as I can. And the cost will be, I've now introduced this concept of a gray zone. Or I can eradicate gray zones and I can just say, I'm going to use a single cutoff. That's all I'm going to do. And I'm going to force a clinical decision. And all I'm doing is I'm going to make all the numbers numerically worse because I'm taking, who I would normally say I don't know, and I'm forcing a decision on them. So, that's probably a different episode altogether.
Yeah, and it probably is, but it's got to get resolved because indeterminate zone of 30% leaves everybody uncomfortable. And it's simply a question of having minimal values for sensitivity and specificity that you can't hit at the same time.
Right.
And by the way, the rest of the world is a coin toss. If you're doing better than random, you're doing something. Now the question is, how much better than random do you have to do to shrink the zone? All right, let me just take a couple of minutes and talk about the other high points of the, or low points, if you will, the regulatory presentations. To me, the most important thing was this idea about running parallel trials that both encouraged it. It was interesting to see the different styles of the presentations. FDA basically says this is, and Schabel for EMA from German explains why everything is, and sometimes in fairly dismissive terms. So his money quote to me was, I love this quote. I don't love this quote because I like it. I love it because it's so indicative. The magic bullet for the biomarker to replace histology, the so-called predictive biomarker, has not yet been presented. And Suneil, that goes right against what you just said, right? If I need a magic bullet to replace a biopsy, which, by the way, isn't very good, then what am I doing here? Particularly in patient treatment, not merely in clinical trial work. It's also noteworthy that between Brexit and the pandemic, EMA now says they're not even going to start to finalize their concept paper until the second half of this year. Will not complete it until the second half of 2022. That may not be news to everybody or anybody listening to this, but it's worth noting. And FDA restated the idea that their phase 1 and 2A trials will not require biopsy, that those are places where NITs are really all you need, but 2B and 3 will, at least until we have better resolution. And then finally, the interesting thing is that Schabel referenced the NAFLD issue and asked if that mattered in a regulatory setting. And I think the point he was making is that the definition that they're now using for NAFLD is a definition that might yield more predictive patients and better results over time. To me, that misses the point. I think NAFLD is about two things. One is about branding and nomenclature. And the second is it's about letting the right be the enemy of the good. Is that NAFLD solves a couple of problems, but the problems it doesn't solve, it gets you further away from ever solving, and we have to decide how we feel about that. And I think in general, the Americans view it one way, the rest of the world might view it slightly differently. We'll see. But it was interesting that he felt compelled to bring that into this presentation at all. And then to suggest that over time, NAFLD might lead to a regulatory path he would like better. So we lost Jörn to his birthday and Manal because her schedule got away from her a little bit. Delighted to have had them. I want to ask you folks to answer one or both of two questions, which I will as well, and then we'll wrap up. So question number one, what's the overarching message you take out of today? And we might have just touched on all that, but then let's hit it briefly. And then where do you think the message you take out of today will find its greatest value in fatty liver world?
I suppose the overarching message that I heard today was that non-invasive technology is stronger and stronger as we move forward, and that there's certainly very exciting work being done in breath testing, the urine testing, to really push, and I know she's not here today, Donna Crier's wish for beyond the biopsy. I think there was also a fair amount of discussion. There was a couple of presentations on the strength or not the strength of biopsy and some of the issues with it, which again summarised very nicely what we've discussed on the podcast about intra and intra-observer variability. So I think we're moving forward. I'd like to see a little bit more patient involvement patient and end user in this conference, because I think there's a lot of people listening today who don't actually interact with patients and don't necessarily appreciate some of the problems in these non-invasive techniques, because you've got to engage a patient. So I think moving forward, I'm very excited by what's been discussed today for the future. And I think the strength that we're doing now for NIS4, NAFLD Fibrosis Score, all of these non-invasives and being able to track patients and FibroScan, getting more accurate, things like that, I'm really excited by, and particularly for my patients and anybody who we're going to diagnose in the future with the guideline changes, we hope.
I echo a lot of similar thoughts. I think it's interesting because I don't go to as many conferences as I would like to go to, and when I do step into them, it's nice to see data's advancing, new technologies are evolving. Just to put into perspective, GLIMPs, when I originally saw them, weren't in humans, right? And now they're in a phase 1 trial. So, that's significant. That's a significant advancement. Breath-based diagnostics advancing. Haven't heard anything about that since Excellence, years ago. So a lot of positive momentum. I think we need guideline changes or some movement there to kind of point the needle in the right direction, point the needle in a specified direction. I think a lot of concerted effort, but maybe a little bit more zigzagging than kind of straight shot activity, but that's still progress, right? And I'll take progress to no progress. So I think that's awesome.
So this was Diagnostics Day at this meeting first. Tomorrow they'll talk a lot more about drugs. I agree with everything that's been said. I think, Louise, beyond the biopsy might actually be a double entendre, which is it's where we want to get to. But then once we get there, the issues are going to change pretty dramatically. And I think we heard that in Manal today, right? Gee, this breath stuff is interesting. This urine stuff is interesting. How biologically influenced is it? So there will be those who will accept any meaningful improvement in ability to diagnose that is not expensive and not intrusive. And there will be those who will insist on a higher standard of academic level proof, even if it means that we simply decide to ignore the kinds of errors that we don't want to look at and not deal with and not be able to take this as readily to primary care because they can't handle it. So biopsy is malign for so many reasons that it's an easy thing to be against. But once that's defeated, you can start to see where the debates might take shape. Now, personally, I think I land where both of you do, which is I'll plant a flag firmly on the side of let's get as many patients tested as possible, the easiest way to test them. And then if we identify that there's reason for concern, I can figure out how to be more precise. That you could look at GLIMPs, for example, ultimately, or urine, even if you can't do a very good job of mediating environmental effects. And for all I know, they might do a great job. I don't really know their work yet. I hope to. But even if you can't do a great job, if all you can do is start to rule out people that you don't have to worry about, right? And then let environmental effects, heck with it, we'll then go do something else from there. We will have achieved a massive amount, right? And if limonene is proof of cirrhosis and we still have lots of people cirrhotics who haven't been diagnosed, then giving everybody some kind of breath test every time they walk into an endocrinology office would be huge. So I think all those issues are yet to be worked out. I'm extremely excited about some of what we saw. You can just also see where the debates are going to come from. Okay. With that, I'm going to thank Jörn, who by now should be well into birthday dinner, and Manal, who should be at her next appointment. And you two folks, particularly, actually each of you, particularly Suneil, from going right to his presentation into this and wrestling with bulky audio, and Louise, because I don't know what hour it is there, but it's late. I'll see both of you tomorrow. We are not doing a business close at the end of this. I'm just going to say to everybody, we'll be back tomorrow with Naeem Al-Khoury and Ian Rowe, and we'll be talking a lot more about the drugs. Until then, everybody, if you're attending this conference, enjoy tomorrow. Stay safe, stay healthy, get some rest, surf on, and we will see you tomorrow. Bye-bye now.
Join us again tomorrow when Naeem Al-Khoury and Ian Rowe sit in with Louise, Suneil, and Roger to discuss Day 2 of the 4th Global NASH Congress, right here on Surfing the NASH Tsunami.